All right. Good afternoon, everybody, and or morning or evening, wherever you happen to be, and welcome. On behalf of the Department of Nursing at Appalachian State University and our partners with Creative Nursing, I'm honored to welcome you to the virtual launch of Creative Nursing, Volume 31, Issue 2, Amplifying Seldom Heard Voices and Dismantling Oppressive Structures, Mental Health in the 21st Century. This is hosted by Appalachian State University, and I'm Dr. Tammy Haley, the current chair of the Department of Nursing at Appalachian State University. Together, today we're gathering not only to celebrate the publication of this important issue, but also to reflect on its purpose and power to bring forward stories, perspectives, and research that challenge us to see mental health through a more inclusive, justice-oriented lens. Let me begin by sharing a bit about Appalachian State University. We are nestled in the Blue Ridge Mountains of North Carolina. Appalachian is nationally recognized for its commitment to sustainability, community engagement, and high-quality education. The Department of Nursing, housed within the Beaver College of Health Sciences, reflects that mission by preparing compassionate, evidence-based nursing professionals who are ready to meet the evolving needs of individuals, families, and communities across diverse settings. The department is proud to foster innovation in education, equity in practice, and advocacy in healthcare, all of which are at the heart of this issue of creative nursing. Our faculty and our students are engaged in cutting-edge research and experiential learning that addresses real-world challenges, including those that we'll be discussing today. This issue of creative nursing invites us to look deeply into the questions that define, sorry for the chimes, that define mental health in our time. How do we center historically marginalized voices in care and research? In what ways do systems and structures still create barriers to wellness? And how can we, as a collective of scholars, practitioners, students, and thought leaders, contribute to meaningful and lasting change? I look forward to hearing from the contributors whose work spans a wide range of vital topics, from adolescent mental health and social media to pain responses in preterm infants, innovative educational tools and simulation technologies, and deeply human explorations of fear, identity, and healing. These voices come together to provide a unique perspective of insight and impact. These discussions aren't just academic. They're urgent, they're personal, and they're calls to action. Whether you're a nurse educator or researcher, a student or a community advocate, I hope that you will feel free to engage fully, ask questions, challenge assumptions, and most importantly, let today be the beginning or the continuation of your own commitment to amplifying voices that have too often gone unheard. Thank you again for allowing Appalachian State the opportunity to host this discussion. We're really glad you're here. And at this time, I'd like to introduce Marty Lewis Hunstiger, Editor-in-Chief for Creative Nursing.
Well, thank you, Dr. Haley. Before I dive into anything I was going to say, we have a thing here, which is Sarah had asked to go first, and also Noah. It would work well for him to go first. So my question is, Sarah, hello. Do you have the kind of connectivity where we could let Noah go first, or should we strike while the iron is hot here and let you go first? It looks like she has frozen up a little bit. So what I'm going to suggest, I'm just going to be real directive here, and I'm going to suggest that let's have Noah go first. Do you want to use what you sent, Sarah, or do you want to just talk with your own mouth now?
I can just share and talk if that's cool. Yeah.
That's just fine. This is Noah Doucette, everyone. Here he is from Dalhousie in Canada.
Lovely. Hello, everybody. I'm just going to quickly share my screen and give you guys a few slides that you can see. And I apologize for making this so complicated. My parents' flight was delayed, so that's why I'm just going to quickly shuffle this and go ahead and give you a quick little talk. So this is mine and Dr. Jennifer Lane's article titled "Understanding the Meaning Attributed to Patients lived experience beyond a diagnostic label, applications of interpretive phenomenology to nursing practice. And I'd like to sincerely thank Creative Nursing for the opportunity to present this article at this launch event. So throughout this presentation, I hope to walk you through why this clinical practice experience was instrumental to reshaping the way I approach caring for patients in an interpretive, phenomenological way. So while working in the transplant setting, I was assigned to care for a patient diagnosed with alcoholic liver cirrhosis, awaiting a liver transplant the following day. While familiarizing myself with the patient's past medical history and observing the way other nurses interacted with him from a stigmatized and often discriminatory way, I began to think about how we can better care for patients presenting with such heavily complex diagnoses. This is where my interpretive phenomenological journey began. Interpretive phenomenology refers to the science of understanding that everyday experiences are imperative to understanding the life world of others. After caring for this individual for an extended period of time, I quickly realized the amount of stigmatization that was projected upon him because of his history of alcohol misuse. Examples of such perspectives were that an alcoholic should not take this organ away from somebody more deserving, and he simply just did not know how to cope. However, after unearthing that this patient suffered the traumatic loss of his daughter more than 10 years ago, this piece of information made apparent that the alcohol misuse was simply a coping mechanism due to being fearful of seeking professional help in anticipation of being labeled an alcoholic. Interpretive phenomenology allowed me to quickly understand that contained within stigmatized diagnoses are opportunities to challenge nurses' and patients' pre-understandings, which ultimately transform one's authentic and caring being. Whoops, here we go. And I will quickly now wrap up by discussing the profound implications that this experience and philosophical exploration has for nursing practice. I like to use an example of a picture from my hometown to illustrate Gadamer's fusion of horizons, which remains a significant philosophical contribution to interpretive phenomenology. For context, these images were taken from the same location, just from different standpoints. According to Gadamer, one's old horizon represents a narrow point of view that consists mainly of one's pre-understandings, while a new horizon epitomizes both one's pre-understandings and the new contextual information learned through dialogue with others. In the case of this patient, the old horizon represents the diagnostic label of alcoholic liver cirrhosis and the stigmatizing beliefs that surround it. However, the new horizon represents a greater contextual understanding about the essence of this patient's diagnosis and life world. Precisely, alcohol was his way of coping with the loss of his daughter, which was not captured within such a diagnosis, and profoundly influenced the delivery of care. This is evident in these photographs, as the new horizon captures many other aspects of my hometown than the more focused picture of the old horizon. In essence, a fusion of horizon allows nurses to capture the incompleteness of their pre-understandings in order to broaden their contextual horizons and optimize the delivery of holistic, person-centered nursing care. And I invite you to read the full article if that is of interest to you, and I am more than happy to chat via LinkedIn, and there's my little profile. And once again, thank you so much, Marty, and the rest of Creative Nursing for the opportunity to publish with you guys. It's been a great honor, and have a lovely day.
Oh, well, thanks, Noah, and safe travels. Noah's article is open access, so you can read that anytime. I get to stick in my oar just a minute to say that when you talk about contextualizing diagnoses, over and over again, when I was editing his article, I would say to him, there is not such a diagnosis as alcoholic liver cirrhosis. There's liver cirrhosis, and a subset of people who have liver cirrhosis are alcoholic. And the fact that they are alcoholic has huge implications for everything we do to help them and treat them. But you can't call it alcoholic liver cirrhosis, and I think you complied with that. And we can talk more about that in the Q&A. And if you aren't back, I'll try not to put words in your mouth. We're going to be talking more about Noah's article because we have a companion article about this methodology of interpretive phenomenology. Thank you, Noah. So I hope you can come back. Our speaker who was going to go next, Sarah Newman, is in Ecuador, and it sounds like she has lost connectivity. She's going to keep trying to get it back, but she may not. So we're going to just go ahead and proceed with our order, and then we'll figure out how to present her material. Because I know Linda Sue Hammonds can do it. So in the meantime, I'm just going to go back and thank Dr. Haley again for her warm welcome. We're so grateful for your hospitality. Your university has been such a strong partner with us for years. And so thank you for hosting this. I am joining you from Minneapolis. That's where I am, and it's 1:11 in the afternoon here. And the Mississippi River is right outside my window. And I live on land that is the traditional, historical, and legal home of the Dakota people. And another group of people, the Anishinaabe, and others also lived here. There's a place that's particularly sacred to the Dakota people called Owamni, which means swirling waters. It's just right outside my window. And it used to be a whirlpool there until development changed everything, and now there's restoration going on. I want you to know that I'm personally committed to honoring and supporting their ongoing legal and spiritual connection to this land. And our journal is also committed to presenting voices of Indigenous experience, including the wisdom and knowledge of healthcare that's been marginalized or silenced altogether in the past. Our overarching theme for this year, as Dr. Haley said, is amplifying seldom heard voices and dismantling oppressive structures. The theme of issue number 3, the next one that's coming out in August, is Indigenous voices sharing our stories and leading change. And our guest co-editors for that issue are Misty Wilkie and Teddy Potter, who are both professors of nursing at the University of Minnesota. And so please keep your eyes peeled for that issue because it's wonderful. We're in the midst of preparing it now. On behalf of the board, the editorial board of Creative Nursing, our official name is Creative Nursing, a journal of values, issues, experience, and collaboration. And I welcome you to this celebration. We have a growing community of scholars, thought leaders who are willing to write about and talk about challenging issues. Some of this is discourse that many journals avoid, but we welcome it. We don't seek it out. We don't seek out controversy, but when it comes, we welcome it. And it's so exciting for me to see the authors in this journal issue who have published with us before, including Lori Steffen, Linda Sue Hammonds, Sarah Newman, Mohammed Al-Sadi, Susan Lane, Jennifer Lane, Atisham Yunus, and Shahzad Inayat. And if I missed anyone, we love you all. We also have another member of our community of scholars. His name is Altu Ipekci. He's my neighbor who speaks Turkish, and he helps me with my pronunciation of Turkish names and so forth. So in 2025, with our mission of amplifying seldom heard voices, we are still confronting complex issues, and we're listening for narratives that are often suppressed or discounted. In this issue, Mental Health in the 21st Century, we report on the effects on our spirits of the increasing stress, complexity, and change. I don't think I need to convince anyone that's what's going on, that are coming at us faster than we as a species have evolved to cope with it and adapt to it. The sources of our articles in this issue, in addition to the people who are here today, are Australia, Brazil, Canada, Ecuador, India, Indonesia, Jordan, Palestine, Portugal, South Korea, Turkey, and the US. Shows that these effects are being felt all over the world. The title of my editorial is Activities of Daily Living. And I chose it. This editorial has 2 concepts that are throughout really all of this articles. One is that mental health is a continuum. And the other is that it's our activities, it's our functioning, our activities that comprise our humanity. And it also has turned into a measure of mental health. This spectrum of mental health is from coping and resilience to significant vulnerability, from pleasure, psychological pleasure, to psychological pain, and from effective performance to struggles with, and sometimes the inability to do the things that help us live in the world. That's why I called it Activities of Daily Living. This is a term that's familiar to all nurses, and we usually use this to talk about how we are helping those we serve. We're helping them to do their ADLs. We're helping them to have the best quality of life, whatever that looks like to them. In the context of mental illness, giving this help can be even more complex. As I was writing this, I thought of a friend who was looking back at a time when he was in crisis and I was trying to help. And he said, Marty, I didn't even know what I wanted. If I had known what I wanted, I wouldn't have been as bad off. The National Institute of Mental Health definition of serious mental illness includes this idea of how we function as a measure of our mental health. They define it as a mental, behavioral, or emotional disorder resulting in serious functional impairment, which substantially interferes with one or more major life activities. That's built right into the definition of mental illness. And other definitions echo this. What I'm going to say is, to an outsider looking at you, it's not how you feel, but how you are functioning and how you're making me feel that determines the label I give you of whether you're mentally ill or not. As Lori Steffen says, I'm sorry, Lori, if I'm stealing some of your material right now, but here's what Lori has to say about this. A broader definition suggests that mental health is a matter of degree and duration. Everyone experiences mental health issues to some degree at some point. Commonly experienced anxiety about an upcoming event or the results of a medical test, grief at the loss of loved ones or relationships, struggling to cope with a new diagnosis, depression following the birth of a child, which everyone would assume is a joyful event, but for people with postpartum depression, it's significant. Situational events can cause short-term mental illness, but for some people, this can progress to chronic, life-altering illness. All of our articles illustrate in some way these concepts of mental health as a continuum and how we use functioning in the world as a measure of our own mental health and others' mental health. That's all I'm going to say about the topic now, because everyone here has done such a wonderful job talking about it. We have so many wonderful articles. After they've been presented, we'll have a moderated open discussion. You are welcome to put questions in the chat now, but we'll deal with them at the end. And it also sounds like Sarah Newman will not be able to present. So Linda Sue, who is her co-author on that article, will present for her, and we'll figure out where to put that in. The digital version of this whole issue is on our website, and that document, along with the recording of this launch event, is going to be on our website, along with the annotated table of contents. And we'll post those links in the chat as well, so please watch for those. I'd like to say too that if you're, some of the articles are open access, others you need a subscription. And if your library doesn't have a subscription to Creative Nursing, there's a link on our website right on the right-hand navigation bar that says recommend to library. I'm just saying. Okay, so I'd now like to introduce Dr. Linda Sue Hammonds, who is one of our guest co-editors of this issue of the journal, and she's co-author of 2 articles in this issue. She's an associate professor in the College of Nursing at the University of South Alabama. She'll introduce our first presenter, co-author, Sarah Newman.
Hello, everybody. So I'm going to introduce us, and I guess I'm going to be the speaker as well.
Sorry, I misspoke.
That's okay. So I'm Linda Sue Hammonds, and I am a professor with the University of South Alabama in the College of Nursing. And I teach mainly the Doctor of Nursing practice students. Dr. Sarah Newman has a PhD in English and rhetoric. And she isn't a nurse, but she plays very well with nurses. So we're good friends. And she was the lead author, actually, on this particular article. The third author is Dr. Melanie Baker. And Melanie recently left the University of South Alabama, but she was my colleague for many years. And she was also part of this article. So our article is about a collaborative online international learning experience that we did. For short, we call that COIL. If this isn't something that you've been exposed to, it's something that you might want to do. It's a wonderful experience for nursing students and for their faculty, because it connects the students with students all over the world, and the faculty who are teaching them. And in this case, it was a project between the University of South Alabama and the Universidad San Francisco de Quito in Ecuador. And that's where Sarah teaches. And the students involved were students in our Doctor of Nursing practice program who were in the course where they plan their doctoral project. Sarah's students were undergraduate students in their first semester at the university. And as it would be, she wasn't even teaching an English course. She was teaching a science course. She had been called upon to teach this beginning level science course. So there were, I can't give you the exact numbers, but we had, maybe 15 or so doctoral students paired with probably about 15 or 20 undergraduate students. And the focus of this project was mental health and environmental justice. And if you do anything at all with this, or even in the news, you sometimes can see articles about mental health and environmental justice issues. So that was the focus of this collaborative opportunity. At the very beginning, we had the students to take a survey. And it was a survey about cultural understanding, because even though we were working on environmental issues and mental health, the main thing that we were wanting to do was to create cultural understanding between these two groups. So at the beginning, they took this survey about cultural understanding. And I can't think of what the full name of it is, but the short version of it is ASK, A-S-K. And it was a survey that was created for the general population because, Sarah's students obviously are not healthcare providers. So we elected to use a more general way to measure rather than something that would be more applicable to healthcare. Then we did some discussions in an online platform about the environment and mental health and how it impacts mental health. And in particular, we used a TED Talk about global changes in the environment and mental health. After that, the students were invited or divided into some groups to do some work with small group work in the development of ideas and posters surrounding the ideas of mental health and environmental justice issues. And in the end, the doctoral students were that term developing a project to improve a mental health condition that was in an area where there is an environmental justice issue. And there were a wide variety of those. And the students in the doctoral program made their posters about their project that they were developing that term. The undergraduate students that Sarah had made posters about what they had learned that term about mental health and environmental justice. And part of a COIL is always presenting what the students learned. And in this particular term, we just presented to each other within the course between the two groups of students. But sometimes we have done things like held a mini conference and invited other people for the presentations and so on. So there's a wide variety of things that you could do. Trying to think of maybe an example of what maybe one of the doctoral students would have done. I know that I had a student in that group who lives in Florida, and that student developed a project with the global changes, making the weather much hotter, but also just a whole lot sunnier, even in sunny Florida. And the population that he chose to work with were adults with ADHD. And if you're not aware, ADHD and the medications that treat it, often there's an accompaniment of sensitivity to light that's associated with it. So they might not come to an appointment because they don't want to go out into the light. And so then, of course, you know, they're not keeping up with their appointments and their treatment and so on. So he did a project to make some changes within the facility that would promote the cooperation of people with ADHD to come to their appointments, changes within the facility, but also he used shared decision making to work on things that patients could do for themselves to make it more comfortable for them whenever they had to go out into the bright sunshine. And that was just the beginning of the project when we were planning it. And we went on further over the next 3 semesters to implement it and disseminate it.
So Linda, if you don't mind, I'm going to go ahead and ask you to wrap up now. I know you're working on the fly because Sarah was going to do this, but
Yes.
do you have any other concrete?
The only other thing that I would say right now about it is that at the end of it, both students in, you know, both the nurses and the undergraduate students did have growth in their cultural understanding through participating in the project, even though the project was not about that.
Mm-hmm.
The project itself was about, you know, the environmental justice and mental health.
Right. Well, so thanks, Linda, for jumping in with this. And I'd encourage everyone to read the whole article because the connection between what's going on with climate change and mental health really became much more clear to me after. And I thought I knew a fair amount about climate change, but the effects on population and individual mental health is something that really bears more study. I'm going to propose that Lori go next with hers so Linda can have a chance to regroup before you do your other one. Is that okay?
Yes, thank you.
Okay, great. So I'd like to introduce Lori Steffen, who is a guest co-editor of this issue. And Lori is a nurse consultant for people with disabilities who live in group homes or assisted living settings, but I've known her for decades and she has a passion for mental health. So Lori, take it away.
Unmuting. I always forget that part. Hello, everyone, and welcome. I'm coming to you from cloudy Minnesota in the United States, and it is 1:30 in the afternoon. I want to thank Appalachian State for hosting us. I also want to thank Linda Sue for being my co-guest editor. As we started planning this issue, we had a lot of articles that had been submitted, and we knew we wanted to talk about mental health. And as we started looking at the articles, we realized we had a whole treasure trove of articles that we could include, various different aspects of mental health. in my article, so I'm pleased with the breadth and the depth of the articles that have been written about and the work that's happening throughout the world related to mental health. When I wrote my article, which is entitled Mental Health Then and Now, I was looking at some personal experiences and then some things that were happening in the world. When my grandfather was 18 years old, he found his sister hanging in the barn after a breakup with her boyfriend. And it was never discussed. It was a big, shameful family secret that my great aunt had died of a broken heart. That was how it was described. She died of a broken heart. Not that she died of suicide, but it was a broken heart. And I've been hearing a lot of news articles related to celebrities and talking about their mental health, their alcoholism, their depression, their eating disorders. And I realized that 100 years ago in the 1920s, suicide, mental health issues were shameful, secretive, things that people didn't talk about. And in the 2020s, people talk about them, but I realized that I don't really know how much things have changed because there still is a huge stigma. And as I looked at how mental health has been, I really looked at some of the historical origins of mental health. And in the 1400s, there were people in Peru who were actually doing boring holes in people's skulls to deal with mental illness, and looking at some of the practices of burning people at a stake. A lot of the witch trials were related to mental illness, and there were many, many practices that were quite challenging for a person to survive. So they had their mental illness, and then they had bloodletting, or they were incarcerated, or they were not given tools to deal with their mental health in society at that point. So things have changed. We have a lot more options for treatment. We have a lot more opportunities for talk therapy and behavior therapy, a lot of medications, which provide great relief to people with chronic and persistent mental illness. But yet, the stigma of mental illness still remains. And we often hear people talking about our clients, and I saw this in the hospital too, that people are, even nurses are really afraid to care for people who have mental illness. I was working on a unit where a person came in with a cardiac issue, but he also had schizophrenia, and the staff were very, very nervous about caring for him because he was schizophrenic, he was crazy, he was, the labels that come along with it. So I wanted to present a little bit of context about mental health then and mental health now. And I'm grateful that we have so many opportunities for technology to help people with their mental illness, whether that is through apps on their phone or through programs. There's in the United States, there's 988 where people can call for crisis counseling. It's a free phone call. It's like 911 for medical emergencies, and 988 is for mental health emergencies. So we have many options. Payment for mental health is, we're supposed to have more equity than we used to have. But some people still do not seek treatment for cultural reasons or for personal reasons. They struggle with mental health issues. They don't want to see a counselor. They don't want to take medications. They don't recognize what an impact mental health is having on their function. And so there's this entire group of people who continue to experience symptoms from mental health. And even though help is available, they don't seek it because of the stigma and the shame and the silence that continues to surround mental health. So that's what I have written about. It was really interesting to look at all the articles that we chose for this issue, and I'm looking forward to hearing what the rest of you have to say. So with that, let's see, I'd like to introduce Rebecca Allman. She is a almost doctorate from Appalachian State and is one of our co-hosts today. So take it away, Rebecca.
Thank you so much for the introduction. And I'm actually going to share my screen with you all real quick.
Can you turn up your audio just a little, Rebecca? I don't know if any.
I will try. Can you hear me? All right. Can you all see my screen?
Yes, we can.
Lori, I think your discussion was a beautiful segue into the topic on transgender healthcare, because this is also a population of people who are underserved and nurses seem to be terrified to take care of, or not only terrified, but don't take care of people in this population very well because they don't know enough about them. And they think that gender identity is directly linked to mental health disorders. So thank you for talking more about your topic as well. So as Lori said, my name is Rebecca Allman. I am a clinical faculty member here at Appalachian State University. And today I do have some of my dear colleagues and co-authors here with me. So Doctors Susan Lane, Jordan Hazelwood, Kelly Williams. Oh, I'm so sorry. My presentation just went away. Kelly Williams and Dr. Danielle Nunnery. They are here with me. And then we also, this project, a huge part of this project was Dr. Jean Bernard, Mr. Lee Whitman, Dr. Heather Thorpe, and Ms. Mara McLean, who unfortunately couldn't be with us today. But all of us together created and implemented an interprofessional simulation that was focused on transgender healthcare. So current literature really tells us that transgender individuals are at a very high risk for developing mental and physical health disorders in comparison to cisgender individuals. And this is due to a number of factors: social, economical, personal. But I think the thing that stood out most to us is the stigma and discrimination from healthcare providers that could lead to negative outcomes for this community. And a lot of healthcare researchers believe that it's really just a lack of preparation and knowledge from current healthcare professionals where they're not able to provide gender affirming care. And so our thought was, if we are able to create and incorporate transgender specific education and health sciences, that hopefully this would translate into clinical practice for our future health practitioners. There are a lot of words on this, but I would just say that we were super grateful to receive grant funding from the Area Health Education Center for 2 years. And the big differences in these 2 years really involves the technology and how we were able to utilize that grant funding. But as a collaborative team, we developed 2 unfolding case studies that involved 2 separate transgender men who experienced healthcare in multiple settings and with different disciplines. The first year, there were a lot more simulation scenarios, whereas the second year, we were able to utilize these well-developed scenarios, so the hours changed a bit. And then again, in cohort 1, we utilized our institutional learning management system for the students to kind of be immersed into the virtual world. But cohort 2 was excellent because we were able to purchase the virtual reality headsets and a virtual world with support from the university. And so the students were able to be immersed into the setting to care for these specific individuals. So one of the most important things about this is our ability to work together to help students understand that they are not alone in the healthcare setting, and there are other people that can support this patient population as well. So we worked with communication sciences and disorders, social work, and nutrition and healthcare management. For the unfolding case studies, there was voice therapy involved, lots of community resources and support from social work. And then one of the patients actually experienced a pulmonary embolism. And so nutrition came in and was able to provide discharge education for the patient with their medications. So we were able to collect qualitative data the semester after our simulations for both cohorts. And we really just wanted to focus in on the benefits and challenges because this was new for everyone. Some things that stuck out where students really got a lot from hearing the experiences of transgender individuals. We had a panel at the end and they were able to hear those real life experiences. Also, something that I highly recommend for anyone interested in doing a project like this, our standardized patients were actually transgender individuals. They were not acting. I mean, of course, they were being paid to act, but they had lived through a lot of these things. And so they were able to help with debriefing and helping the students understand what people actually go through in these settings. And then students found it extremely beneficial to learn the roles of other health professions because they don't have a tremendous number of opportunities to do that in their education before practice. Some of the challenges is we hired 2 transgender men. There was obviously a lack of experience with transgender women, which students recognized that they would like to have moving forward into practice. It was very time intensive. As you can tell from the previous slides, there were 9 different scenarios. It was 9 weeks long, that first cohort. And then this really struck me. The students were appreciative that the standardized patients were transgender and they had lived through these experiences, but they were also very concerned about their mental health and well-being, just, reliving a lot of the experiences that they had had in the past. So I thought that was pretty meaningful that our students considered that as well. But really, that's the essence of our project. It has been a wonderful opportunity to work with my interprofessional peers and colleagues, and students have really gained a lot from this. So of course, our overall goal is to improve health outcomes and experiences for the transgender population, and I hope that we are headed in that direction.
Well, thank you so much, Rebecca. I'm going to suggest, Linda Sue, that we plug you in at Noah's slot. Is that okay if we do that for your other article?
Yeah, that's fine. Just let me know.
I'll take that as
Just
a
tell me
yes.
when to talk.
Okay, well, you'd be in the slot that Noah Doucette is in since he's now on the way to the airport, presumably. So I would like now to introduce our next speaker, Dr. Teresa Moreira, co-author of the article, Use of Technologies in Promoting Adolescent Mental Health, a Scoping Review. Dr. Moreira.
Okay, thank you very much. If I just want to share my options. No, I can't. It's not allowing me to share my presentation. I don't know why. Oh, it's here. Sorry. Is
There
everyone
we are. Yep.
okay? Can I? Is full? Okay.
Yes, that's false.
Yeah, I'm just presenting this article. Alexandra is not very good with English, so she asked me to do it for her. So I'm presenting this. I'm a professor at School of Nursing in Portugal, and not so sunny today, but sunny Portugal. And I'm just presenting this review that we have done. So what the background of this study is the growing digital landscape of mobiles and apps and VR, IE platforms that at the moment students can and young people can use. And why is so important, these issues, why does it matter, is because these adolescents, mainly 10 to 19 years old, is a critical period on to mental health and an important one for early intervention. The gap that we found is little evidence of the effectiveness of these tools that we want to look at. The goals of this scoping was to map the range of these technologies that used by adolescents, mainly for mental health, to identify the domains that they are studying and they are helping, the benefits and challenges and the gaps that we can find, and of course inform and try to clinicals, educators, and policymakers on this matter. So the methods that we use the GBI methodology. We use 3 databases, PubMed, CINAHL, and PsycInfo. The time last one was in June 2024. And we had no publication limits. Inclusion criteria for this study, we use qualitative, quantitative, and mixed methods, adolescents from age 10 to 19. We use Prisma, and in the end, we end up with 16 studies included. The study characteristics, we have 12 countries ranging from North America, South America, Australia, Europe, and the publication year was from 2019 to 2024. The interventions that they use more mobile apps, online CBT platforms, virtual reality environments, therapeutic games, and AI-driven chatbots. The main domains that we found on these articles, anxiety was the main issue study in 9 of the articles, depression in 12 studies, stress was also found in 2 studies, suicide prevention in 2, and mental health literacy in 4 studies. Anxiety used mainly these 3 technologies, mindful and meditation apps. They use Headspace, Smiling Mind, guided breathing, and reported reduction in self-rated anxiety scores. Online CBT platform that use self-paced cognitive restructuring exercises, psychoeducational videos, and quizzes. In AI chatbots, they use on-demand emotional support and strategies via text. Depression, they use psychoeducation apps, interactive modules on mood, and plus notifications for daily check-ins. They use also teletherapy programs like text, audio, videos, and this one is a little bit better for flexible schedules with licensed therapists, and peer support networks as well, where they use anonymous forums for they were moderated by professionals, and this one improved the sense of belonging and reduced isolation. Stress, we mainly found these therapeutic games, gamifications, and they were highly engagement reports on these ones. time stress monitoring. They use personalized feedback and goal settings. That was very good as well, and guided platforms for relaxations. They use audiovisual exercises for progressive muscle relaxation. They also study suicide preventions, and where they use crisis response apps, on-tap access to emergency contacts, all i.e. Monitoring on social media. They use natural language for flagging posts with suicidal posts, and they can check that, and they alert the clinicals or the person who's using it. Also, on suicide prevention, they use the 24/7 chat box that is anonymous, always on conversational support for these situations. In mental health literacy, they use gamified learning models, VR and IE educational tools, interactive tutorials, and adaptive learning pathways. So the benefits that we found are the use of these apps is the accessibility, 24/7 reach, and the barriers is low and on. They can be anywhere and they can use it. Personalized and engaging as well, because this type of adolescents used mobile phones all the time, and this type of situations is very engaging for them, and is more private. They can use it anytime in any situation. Is also a benefit is the early intervention. There is real-time monitoring for support, and they can get help sooner. The challenges of this type of tools is the privacy and data security. These type of situations, as we know, can have this virus and other situations that can access their data, and is an issue that needs to be sorted. In here, they also found that there is a different access based on their socio-economic status. Some people cannot have access in poorer countries to the internet or this type of situations. Another situation that is very well studied is the potential for dependency on time screening, and also they can be a bias of the algorithm, and there is could be a risk of reinforcing harmful content on their phones. So implications and what next steps for this type of situations. For clinicals, valid digital tools, get them validated, integrated on the training and on selection and on monitoring this type of programs. Researchers, there is a lack of large-scale RCTs with diverse populations to see if these tools do help these students, and if is a good, if they really gonna help them improve and their mental health on this type of population. Policy makers really they need to establish guidelines for privacy. We need to have algorithm transparency to avoid this type of situations. So this what we need to do is balancing these innovations that are here to help our adolescents with the ethics and these issues with privacy and equity and transparency and I think this if we found a middle ground, this will be great tools to help our adolescents. And thank you for attention. And I just finished. I can't hear you. Sorry, Marty.
Marty, you're muted.
We can't hear you, Marty. No, muted. Muted.
You're still muted, Marty.
Okay, sorry about that. That's what you were trying to tell me. So I'll start over again. Thank you, Teresa. And I love these slides. Not everybody does slides, but they are so valuable. The slide of yours that I'm going to be talking about next is the one that says risks, because we have a companion article that looks at this issue from a different way. But also that slogan that you have at the end, everyone, when you look at this recording, go back and look at that last slide, because that closing thought is so wonderful. So I'm now going to briefly present an article. In a way, it's a companion article to this one. And also in a way, we should have done this other one first, but not really, because if there's any consensus at all about what to do with adolescents and their use of screens, the one consensus is that ship has sailed. There is no way that we can walk that back. They are going to be using their screens, and it would be pretty hypocritical for me to say they shouldn't, because I am very dependent on my phone these days. When I woke up this morning, it was my phone that had my email. That's how I knew that some of the authors weren't sure about the time of this thing that we're doing now. So they're going to be using these devices. And so the question is, what do we do about it? So what Dr. Moreira and her colleagues have presented is, how can we use these as a force for good? But our author, Kristen Burgess, who's a PhD student in the School of Nursing at the University of Texas at Tyler, she's also a DNP prepared nurse who is perceiving changes in the mental health of the teenagers that she cares for in her practice. And she sees with her own eyes their use of social media as a factor in these changes in their mental health. So she has done a scoping review. I'm sorry, Dr. Moreira's group was a scoping review. And if I'm quoting from their article, the research question was, what are the positive effects of using educational technologies in promoting mental health among adolescents? That was your stated research question. And your search words included health promotion, mobile phones, technology, and mental health. So Dr. Burgess's article is a narrative review, which is rather similar in scope. Her search terms included social media use and adolescent mental health, social media use and adolescent depression, anxiety, social media use and adolescent suicide. And her stated goal was exploring the relationship between the decline of adolescents' mental health and the use of social media. So you can see that both of these studies are equally rigorous in how they apply what we require of a review. How you word your research question or your stated goal and your search words determines what happens from there. So the results report a significant increase in depression, anxiety, and suicidal thoughts and behaviors in young people ages 13 to 19 when you use these search terms as she did, and that most of the research published from 2016 to 2024, so the newer things, Dr. Murray said they didn't have a early limit. This is from 2016 to 2024, point to social media use as a contributing factor. She wound up with 30 articles that fell out then, and those are the ones that she analyzed. So the problems that she identified are happening in many places. When I was preparing this, I didn't look at each article, but just going from the titles of the articles that are in her reference list. They are from Canada, I'm sorry, Australia, Brazil, I put them alphabetically, Australia, Brazil, Canada, China, Egypt, Jordan, Malaysia, Norway, Spain, Sweden, and the US. So this is happening all over the world. As a narrative review, this study generated some themes, and these are the names of her themes: negative psychological effects, negative physical effects, addiction, fear of missing out or FOMO, cyber victimization or cyberbullying, contagion phenomenon, and adolescents' low perceived support, perceptions of low support from their parents. So these are issues that this previous presentation called out in their slide about risks that are weighed against the benefits. This is what this author, Kristen Burgess, is focusing on. So she summarizes that adolescents are suffering from a variety of issues related not only to the way they use social media content, but also the amount that they consume daily. And her most important recommendation is for routine screening of adolescents for depression and suicide risk. So I encourage you to read the full text of both of these articles that show us both the benefits and the concerns about this technology being used by this vulnerable group of people who are our world's future. The next two articles are more along the line of prevention and how can we make people's mental health better to begin with? How can we support them in the kinds of mental health challenges that they face? And our first presenter, I'd like to introduce Noor Hassim. She's going to tell us about imposter syndrome among university students and what we can possibly do about it.
Yes, let's share my screen. Is it clear?
Yes.
Yes, we can see your screen.
Yes. Thank you. Good afternoon, everyone. It's a pleasure to be here with you. I'm honored to present our article alongside with my colleagues and co-author Noor Al-Qaisi, Noor Ashraf, and my dear mentor, Dr. Mohammed Saadi and Dr. Jumana Shhade. Okay, let's begin with our article titled as Imposter Syndrome Among University Students, Impact on Level of Stress and Anxiety and Depression. Maybe some of you not familiar with imposter syndrome, so let's begin by the definition. Imposter syndrome is a psychological phenomena where the individual, despite their success, achievement, and full evidence of competence, doubt their self and ability and afraid of being exposed as fraud. Students who recognized to have imposter syndrome behavior had a cyclical pattern of anxiety and fear of not meeting an expectation when they are completing a task. Even if they're completing successfully, they just had a short period of relief. Then they re-enter the cycle upon receiving a new task. Our study objective was to explore how common imposter syndrome among university students and see if there is an association between imposter syndrome and psychological parameters like stress, anxiety, and depression, and some demographic variables. We conduct a cross-sectional study at public university. Our sample include 1,120 students across different specialty We use two validated tools, SEPS and DAS-21. The key findings of our study was that 47.5% had average experiences of imposter syndrome, 34.7% had frequent experience of imposter syndrome, and 7% had intense experiences of imposter syndrome. Imposter syndrome was observed across all student group, regardless of gender, academic level, or GPA, and imposter syndrome positively correlate with depression, anxiety, and stress. Our recommendations are early identification and targeted intervention are crucial to mitigate imposter syndrome and its associated mental health challenges among students. Train faculty within academic setting to support the student and reduce stigma associated with imposter syndrome, to encourage open communication and providing supportive environment, and to integrate mental health into student support program. I'm more than happy to answer your question either on the meeting or after the meeting. This is my contact information. Thank you for listening and attention.
Well, thank you so much. Yes, and please save our questions for the end. And I mean, I have my own take on imposter syndrome, which I've told this author before the meeting. My daughter, who became a nurse at the age of 40, and realized what people were thinking she was going to be able to do after a 16-month accelerated program. She knew exactly what imposter syndrome would mean, not as a student, but as a new nurse. So, I actually, when I said there are 2 articles about how to help people stay mentally healthy, there are actually 3. And this is the second because this is about using simulation education as a way to help nursing students develop communication skills. And our presenter is Dr. Jalad. Samar
Hello,
Jalad.
dear. Nice to meet you again. I want to introduce myself. I am Samartha Jalad, PhD, registered nurse, assistant professor in nursing education, in nursing department, in health professions faculty at Al-Quds University in Jerusalem, Palestine. I am coordinator and educator of the simulation courses for Nursing Simulation Center. I am hold PhD in nursing education for virtual reality simulation as learning and teaching strategy for acquiring skills in nursing education and associated developing nursing curriculum and improving learning strategies and methods related to various skills, such as critical thinking, problem solving that facing nursing students in the practice field. On the other hand, I hold a master's degree in management and leadership of nursing, which I'm assisted in being effective in issues relating to organization and administration that nursing encounters. And I am coordinating leadership and management courses among undergraduate nursing students in nursing department. Now I want to share my presentation related to my article that presented in Creative Nursing Journals, the effectiveness of simulation-based education on educational practices of communication skills, satisfaction, and self-confidence among undergraduate nursing students. Firstly, nursing education nowadays is an interesting and critical education field to create professional and highly qualified nursing in the society, qualified nurses in the society who have the required skills to solve and deal with different health problems and issues that they confront.
So Dr. Jalad, can I just, what I'm seeing on my screen is still the menu. It hasn't opened yet, the presentation.
Oh, really? Okay.
There we go.
Now?
Yep.
Okay. Simulation is highly effective methods used to create realism characteristics that closely resemble real-life settings and situation. It involves specific activities designed to mimic the clinical environment, aimed to demonstrate procedures and enhance decision-making and critical thinking skills. Important of the simulation, it is teaching tool for education, training, and improving the quality of student performance. It is an assessment tool by assessing the student's performance. It is the best alternative solution to overcome the problems of using the real patient in teaching, such as ethical legal rights, lack of critical events that are source of learning. Communication and specifically SPAR technique or SPAR tools. Communication, it is the process of sharing information using a set of common rules, and it is a process by which information is exchanged between individuals through common system of symbols, signs, or behavior. Why SPAR technique? SPAR technique is a tool that allows health professionals to communicate clear elements of patients' conditions. SPAR is communication framework that facilitates the sharing of information between team members, encourages quick response times, and places emphasis on providing quality care. SPAR is abbreviation for situation, background, assessment, and recommendation. Problem statements, why we discovered this topic, because in my country, in Palestine, clinically practical education conducted in hospitals suffer from close or poor both work quality and proficiency, unexpected or extraordinary clinical settings where there is shortage of human resources and equipment. There is shortage of instructors as the number of nursing students ratio is large and needs an appropriate number of experienced or expert instructors. Decreases student satisfaction with nurse practical education in clinical practice, and the opportunity to gain sufficient clinical competency through practical education is limited. There is gap and deficiency in the nursing graduate students' competency and skill, poor communication skills in healthcare centers and hospitals, lack of studies and investigations that examine the effectiveness of simulation-based learning in developing communication skills for nursing students in Palestine. There are significant number of errors that nursing students make during clinical training in hospitals. Significance of this study, there is an increasing involvement and necessity for existence and developing of simulation-based learning. Simulation-based learning and education gives the nursing students the opportunity to implement learning, perceptual and psychological skills of learning, support nursing students to obtain the required competency and skill for efficient and successful thinking and assessment, solving the various problems that they may expose to them in real conditions or real cases, improving their skills in making sound and accurate decisions. Aim to this study to examine the effectiveness of simulation-based learning on the educational practice of communication skills, satisfaction, and self-confidence among undergraduate nursing students. We obtained ethical consideration of the IRB Quds University before signing this study. Methods, study setting, it conducted on the simulation center in nursing faculty and the health nursing department of the health faculty at Al-Quds University. Study design, quasi-experiment design, one group, pre and post test, population, all of the nursing students, first year nursing students who registered a fundamental nursing course or basic nursing course. They 247 students. The sample 112 students for pre and post test. We did data analysis by SPSS version 25, ANOVA per t-test, sample, independent sample t-test. Cronbach alpha, reliability to examine the reliability of the questionnaires. Data collections tool, we use a personal information form. We ask the students related to their gender, age, average, place of residence, type of study. Another questions related yes or no. Did you previously work as nursing assistant or nursing aides? Information technology skill level at enrollment. Which digital tool used during coursework? Are you satisfied with your simulation-based learning experience? Another instruments or tools, we use educational practices questionnaire, student version. This version developed by National Nursing Association and NLN 2005. Student satisfaction and self-confidence in learning, also developed by National League of Nursing and conducted by Chickering and Gamson in 1987. Findings in our study, you see here related to variables educational practice questionnaire, active learning, collaboration, diverse ways of learning, high expectation, all of these total education practice for in the pre-test, the mean 3.65. In the post-test, the mean 3.91. Student satisfaction and self-confidence in learning, pre 3.86, and post 3.90. If you see also p-value significance and collaboration and high expectation and education, total education practice. Also, Pearson correlation among study variables, pre and post, simulation-based learning for total education practice, satisfaction and self-confidence is too high. In post-test, also too high pre-test. And significant on both. Discussion, we saw these results indicate that essential features of educational practice after simulation sessions for communication skills were arranged as firstly, diverse ways of learning, then high expectations and active learning, and finally, cooperation. There was a significant differences between cooperation and high expectation. These results may be attributable to dynamics and complexity in clinical environment in which communication and efficient teamwork among healthcare professionals is very important to meet the needs of the patients, and collaboration take place in all stages of nursing process to achieve desired outcome. This is a agree or similar study of Granham et al. 2018. Simulation is considered an effective approach to improve collaborative skills for nursing students to meet learning objectives. In this study, to enhance students' collaboration and awareness in educational practice simulation, different roles and scenarios were designed and prepared in the simulation on standard patients, which take place through distributed role play among students. Students were told that teamwork is common in clinical practice and that team support and cooperation can affect efficiency, cooperation, communication, and leadership, which agrees with the findings of our previous study, Grover and Muhammad 2020. Conclusion, simulation-based learning in nursing helps students to increase and enhance communication skills between students, accurately analyze data in real-life situation, acquire essential competencies and skills, make informed decisions. Also, it enhances patient safety and their health by simulating real-life patient conditions, facilitating problem solving in clinical scenarios, avoiding patient exposure to risk. There are references and my article, which published on Creative Nursing Journal.
Well, thank you very much, Dr. Jalal. When I worked with your article, what I thought about, I'm old enough that the only simulation we had was Resusciani. it's a big,
This is very important
Yeah,
strategy
yeah, it is,
nowadays
yeah.
in all of the world,
Yeah.
on all of the universities, especially in health faculties and nursing department.
Absolutely.
I had a lot of recommendations to make
Are they the ones, are they the
different strategy, yes, different articles, different studies.
Okay.
For example, this study related
I'm
to
sorry, but
quasi.
I'm gonna need to ask, are they recommendations that are in your article?
Yes, yes,
Yeah,
yes.
okay.
In my
So
article,
at
you
this
can
point,
read it.
I'm sorry,
Yes,
I
yes.
need to ask the people to be sure to look at your article, as all of them. And as I said, again, if your library doesn't subscribe to Creative Nursing, there's a link right on our website to say how to do that. Thank you so much,
Okay,
Dr.
thank you.
Jawad, for being
You're
there
welcome.
this late in the night. And actually, the next person is even later in the night. But this is another article on how to help people maintain their mental health. As a preceptor who's oriented so many new hires, Dr. Lishan Muthri Joshi is going to tell us about helping new employees navigate.
Thank you, ma'am. Let me share my screen. Is it visible?
Yes.
Yes, we
Okay,
can see it.
it's
Thank you.
Okay, thank you. It's early morning here, 1 o'clock. So I don't know whether I have to say good morning to you all, or good evening to you all. So I'm Dr. Lishan Joshi, a professor with Cochin School of Business, India. And my study is titled as Unlocking Job Involvement, Helping New Employees Navigate Using Uncertainty Reduction Theory with Psychological Safety as a Mediator. The earnest interest of doing this particular research is especially the India's growing healthcare sector. Because of the growing population and the growing health expectancy, Indian healthcare sector become highly complex, and especially with the newly recruited healthcare professionals facing significant challenges in adjusting to complex and highly demanding work environment that is existing in Indian healthcare organizations. So effective organizational socialization and well-designed job roles are essential for this new hires for the smooth integration into the workplace. So this study explores that how the organization socialization and the job characteristics helps in the job involvement of newly hired health professionals, and how the uncertainty reduction theory is forming a base for creating this kind of a framework for the study. So the first, let me introduce the constructs which I used for this particular research. The first one is organization socialization. This particular aspect means how the newly hired employees acquire the knowledge, skill, attitude that necessary to effectively integrate into an organization's culture, values, expectations, and workplaces. And simple means how an outsider transforms into an insider in an organization. And this is very important, especially in the healthcare sector. And the other other construct is the psychological safety. That means an individual's belief that how much I can express my ideas, ask questions, and take the interpersonal risk at the workplace. It's precisely how much autonomy that a particular person can feel that that I am psychologically safe. It is very important, especially in the healthcare sector. The reason is, even if a nurse or any frontline medical staff commit a mistake, if it is psychologically safe environment, he openly will accept it. And can inform it. And this has great impact on providing the quality patient care. And another important aspect that studied is job involvement. Job involvement means it is how much an individual psychologically identifies with his job. That means the job becomes the central self-concept for the personal fulfillment. Compared to all other professions, if we take the healthcare professionals, for them, the core self-concept itself is their job. So this uncertainty reduction theory is that newcomers, how they using that information that is existing from the workplace and creating relationships, help them in creating all these kind of or navigating through this highly uncertain work environment. So my research question is, especially in India, we all know that this is a society, highly multicultural society. And if we see the fabric of our society, the power distance, the hierarchical hierarchy is very much existing in our culture. Even maybe it's based on the gender, or maybe it's because of the power distance that is present in the healthcare organizations. For example, the medical staff, doctors, nurses, or elite paramedical staff, there is the power distance highly explicitly exists in Indian culture and in the Indian healthcare institutions. So this question that we are asking here, that how the newly recruited healthcare professionals face a significant stress and uncertainty while adjusting to the complex hospital settings. And while organization, socialization, and job design are known to aid the adjustment in their interaction with psychological safety, is shaping the job involvement remains underexplored. We all know that if there is a proper systematic structural organizational socialization process happens, then definitely a new hire will have a feeling of job involvement. But how this interlinking mechanism, that which mechanism helps in the induction program to the job involvement, that is underexplored. So in this study, we are trying to find out that whether psychological safety is playing as an interlinking mechanism or not. So here, if we see, this is the conceptual model that is used for this study, where we are seeing that the organization socialization is positively associated with job involvement and job characteristics, that is the autonomy, the feedback, the job design, that is having direct link with the job involvement. And we are identifying that this particular element, psychological safety, that is how much risk I can take or how much freedom I'm having, how much autonomy I'm having to perform my job, that determines the involvement and that particular workplace. We all know that almost all the healthcare professionals, for them, their job is their self-core concept. So if they don't feel psychologically safe in the initial days itself, the attrition rate or the turnover of the employees in Indian context, it's very high. So this is the reason why we studied this particular the reason behind this particular study. And here we used a quantitative method and we used the primary data, and the sample was the 313 healthcare professionals who started working in the particular concerned organization for less than 6 months. That is, they are newly hired employees from 10 private hospitals in southern part of India. We collected the data, and the scales we are used here is organization socialization scale by Kao in 1994 and the job characteristic model by Hackerman and Oldham in 1976, and psychological safety scale by Edmondson in 1999, and job involvement scale of Lodal and Keshnar in 1965. The analysis, we used IBM SPSS and Bob PLS, and the above mentioned all hypotheses were supported in the study. That means that psychological safety is a mediator between organization socialization and job characteristics. So the theoretical implication is that till date, none of the research have used uncertainty reduction theory to support this particular linkage or creating this particular framework. And another important aspect is job characteristic and socialization process is interlinked or by a psychological safety as the mediator between these two variables. And in the Eastern, the study contributes to limited empirical research on psychological constructs in Indian healthcare setting, showing that Western organizational behavior theories like URT and psychological safety hold explanatory power in Eastern hierarchical and collectivist cultures. Because in the Northern America, many studies have used these constructs, but those cultures were highly individualistic and performance oriented cultures. And this is a multi-fabric Indian Eastern hierarchical collectivist culture also. This particular aspect proves valid. So, and the practical implications of the study is like if every Indian organization, if they are having a very systematic and proactive onboarding strategy, this will help the healthcare professionals prioritize, reduce that the anxiety and uncertainty that the new hires are facing. And if the job design, it emphasizes the importance of job characteristics like autonomy, feedback, and task significance to enhance the employee's involvement and motivation. And psychological safety, that is very important aspect. This will lead to a highly inclusive and team-oriented workplaces in the Indian healthcare sector. So this hope that the study will help to build an inclusive, respectful, and psychologically safe healthcare environment in Indian hospitals. So thank you.
Thank you very much, Dr. Joshi. I have to tell you, if I'm in a Western individualistic culture, what you said about the Eastern collectivist cultures made total sense to me. So I think there is a lot of connection and a lot of crossover. So thank you so much for that. Our next presenter is on video. This is Dr. Suat Tuncay from Turkey, and it's midnight there when the meeting started, so it's like 1:30 now. He sent a video that we're going to share with you now. And this is about helping children who are being hospitalized not be so afraid.
Hello everyone, my name is Suat Tuncay. I work at the Department of Pediatric Nursing at Bingöl University in Turkey. First, I would like to say that English is not my native language, so please excuse any minor language imperfections. Still, I believe that sharing knowledge is a universal responsibility, and I am honored to be here, even if only through the video. I would have loved to participate online in this event, but due to significant time difference between Turkey and host country, and it's already very late at night here. That's why I'm sharing this as a recorded video, but please know that I deeply value this opportunity to the present and connect with the fellow professionals. Today, I will briefly introduce our recent publication in creative nursing, titled Hospital Fear Points and Fear Levels of Children ages 5 to 10 years old, which I co-authored with my colleague Dr. Abdullah Sabu. Pediatric patients are highly vulnerable to fear and anxiety during hospital visits, especially when facing painful procedures or unfamiliar embryos. Although existing literature discusses general fears in hospitalized children, we noticed a gap. What specific moments or situations inside the hospital cause the highest level of fear? The aim of our study was to identify these hospital fear points and to measure children's fear levels across different hospital departments. These are emergency, outpatient, surgical, and inpatient wards. We conducted a descriptive cross-section study with 210 children aged 5 to 10 in a regional pediatric hospital in Western Turkey. We used 3 data collection tools: a demographic findings form to understand the child's background, a hospital fears form, which included both general and unit-specific fear-inducing situations, and the child fear scale, a validated visual scale that measures fear levels using facial expression from 0 to 4. Children and their mothers were interviewed face-to-face after their medical procedures in outpatient and emergency, and 5 hours after surgery in the surgical unit, and on the third day of hospitalization in inpatient wards. Ethical approval was obtained from our university and local health authorities. Verbal and written consent was collected from mothers, and only verbal consent from the children. Across all units, children expressed the highest fear during injections and blood drawing, separation from their mothers, and being forced to undergo procedures. In emergency and outpatient clinics, children feared injection was 326, blood drawing 321, and separation from their mothers 296, when we think maximum is the 4. In the surgical unit, the most frightening aspects were entering the operating room, waking up after surgery, seeing the incision, and being given medications. In inpatient wards, children feared nurses or doctors entering their room, hospitalization, and being away from their parents. Additionally, mothers reported anxiety when bringing their children to the hospital, with average fear scores above 4 for health out of the 10, both for themselves and their children. These results show us that pediatric hospital fear is multi-layered. It's not only about pain, but also about loss of control, parental separation, uncertainty, and environmental stressors. Our findings reinforce the importance of traumatic care and child-friendly communication. Pediatric nurses and hospital staff need to prepare children with age-appropriate explanation, reduce waiting times and crowd exposure, and ensure parental presence during procedures whenever possible. Smartphones were also most common calming tool used by mothers, which reflects a modern but potentially problematic coping mechanism. In conclusion, we believe that recognizing fear points in hospitals can help us build more supportive, safer, and emotionally healthier environments for the children. We recommend further studies and policy-level actions to integrate child-centered practices in pediatric care. Thank you very much for the listening. It's an honor to be part of this knowledge sharing, and I would like to also thank to Marty to this opportunity. Thank you very much. Have a nice day.
It's from Turkey. All right, so I'm now going to move on and then have instead of Noah Doucette, this is Linda Sue Hamilton, who's not Noah Doucette. Linda is going to present an article that she is a co-author on. So go for it, Linda, and 5 minutes. We're saving the 5 minutes, even though we're close to the end.
Okay. Yes, I'm more organized for this, so we can handle this quickly. This was an article, the first author was one of my doctoral students who graduated in spring of 2024.
Now, do you know you're not on screen?
There we go. And she was not in the group I mentioned earlier where we did the coil. She was a student in one of our regular classes. And she did a project about increasing medication adherence in support of mental health for her patients. Melody Cabanec-Dome is her name. And we're all aware of, the problem of medication non-adherence among our patients, not only mental health patients, but every other kind of patient that we've ever taken care of. But her patients were between the ages of 18 and 65 years in an outpatient mental health clinic in the Midwest. And what she did was she used the medication adherence rating scale to measure the medication adherence And she used shared decision making along with the patients to discuss their medications and their taking of them, and to make plans with the patient for adherence to the medication regimen. She used Plan, Do, Study, Act as the underpinning for her project to guide the steps of the project. And Orum's self-care deficit theory was her underpinning for the project because, pulling the patients into their own care through the shared decision making. At the beginning of the project, she administered the MARS to all of the patients, and there were 10 of them, not 10 of them, 7% of them scored 10, which was the highest score, which meant that they were adherent. But there were 37% who scored less than 10. And there were 130 who actually fully participated in the project. And at the end of the project, after the shared decision making, and when the MARS was administered again, 71% had higher scores than they had before. And there were 35% whose scores didn't change. And among them were the 7% who initially scored 10, but some of the others didn't make any positive improvement either. And so, the results of her project were reached. She was able to use the shared decision making to increase or maintain medication adherence to support these mental health patients, their journey. Thank you.
Thank you. This is a really important article, as are all of these, and I'm just going to put in as an editor of this particular article, one of the recommendations I made, it was initially called Decreasing Non-Adherence. And I said, actually, can we put it in a positive way? How can we support and increase adherence? The other thing was, in some of the tools that were used, these were people who were called non-adherent patients, or their adherence was a part of their descriptor. And I said, let's use person-first language. These are patients with mental health issues who are on medications, and their adherence to their medication varies, but they're not non-adherent patients. And Melody was all over that, just did that very well. We want to save some time for discussion, but I also don't want to short the remaining articles, and there's only one that I'm going to tell you about briefly. This is a partner article to Noah Doucette's article. If you can think way back to the very beginning, before he left for the airport, his article was about a patient that he cared for who was alcoholic, had need for a liver transplant because his liver cirrhosis had damaged his liver to that point. And he wanted to understand more about this patient, and learned that this patient had had a very traumatic loss in his family. His daughter died 10 years ago, and he was having drinking issues then and didn't seek mental health help at that time because he was afraid of the stigma and being labeled and so forth. So 10 years later, his liver is in the kind of shape where he needs a transplant. And so what Noah was talking about was the lived experience of this person, because unless you asked him about this previous trauma, you would never have known that. And if you did, you might be more likely to cut him some slack and not say things in the break room like, this patient shouldn't be taking a liver away from someone who's not alcoholic. That's the emphasis of Noah's article. We have a running series in our issues this year by Atisham Yunus, who's our EI editor-in-chief, and then another board member, Shahzad Inayat, about different kinds of qualitative research. And they talk about this particular kind, phenomenology, in their article. This is an open access article, so when you read all the articles, that one, you can read it in conjunction with Noah Doucette's, which is also open access. And the one detail I want to mention about Ahtasham and Shahzad's article is that the philosophers on whose philosophy this interpretive phenomenological methodology is based were all German. They all wrote in the German language, which makes a distinction between experience and lived experience. Those are two different words in German. And the word for experience is Erfahrung. That just means being engaged in an activity and then learning and gaining knowledge from it when we think about it afterwards. That is experience. Lived experience, Erlebnis, is our everyday subjectively experienced world. That's what lived experience means. And this may seem like a really subtle distinction that isn't very useful for us in our everyday nursing practice. But think about it. As nurses and as human beings, we base our actions toward other people on our assumptions about them. That's just the way we're wired to do that. There's nothing evil about that. That's what we're wired to do. But our everyday subjective experienced worlds, our Erlebnis, our lived experience, is where we all live, we and our patients. And we can't know about other people's worlds unless we ask them and then we listen very carefully to what they say, which is what Noah did. So I think about a previous article by Shahzad Inayat about, it was called Dialectical Pluralism in Nursing, which is a pretty heavy title. But then also we've published articles about trauma-informed care, which I think is a term that may be familiar to all of you. Trauma-informed care. And to me, the basis of that dialectical pluralism and phenomenology is this. If you think you know what this person who's standing in front of you has gone through, you better think again. That's my summary of that. Okay, we have 5 articles whose authors were unable to get back to us about participating. And I think in order to preserve some time for discussion, I'm not actually going to list them. They will be in the issue. They also are in the annotated table of contents. There's one about lived experiences of mothers living with HIV. There's one about patients undergoing cardiac surgery and how they experience the ICU. There's one about the comic book that I mentioned from Brazil. It helps kids cope with surgery better. It's told from the standpoint of a kid who's going to have surgery. And then from Australia, there's one where they did a map app for students who were doing clinicals in remote rural places, far from home. And this is an app that helps them find not only their way around campus, but where are the local coffee houses that have free Wi-Fi? Where are the libraries? Where can you find out about housing? This is an app that they came up with. And if we think that doesn't have a connection to mental health, we better think again. So with that, I encourage you to read the full text of all these articles. And if your library doesn't already have that link, once again, that link on our website says recommend to library. So this is the end of all Marty all the time. I'm gonna hand it back to Lori, Linda Sue, Susan, and Rebecca to moderate a discussion of whatever you want to talk about. And we'll go until 3 o'clock. And if anybody hangs around afterwards, I think there's more time on the Zoom meeting if you want to keep talking.
Thank you, everyone, for all your wonderful presentations. It's so exciting to hear all the work that's being done. I'd like to open the floor to questions. Does anybody have any questions they'd like to ask any of our panelists?
If I can just jump in, I kind of feel like I cut you off, Dr. Gillette, and I'm really sorry. But what I was going to say about simulation is when I was in nursing school and for a long time afterwards, the only simulation we had was these big, huge plastic dummies where we practiced, you know, how to do compressions. That was the only sim we had. And the first time I ever did compressions on an actual patient, it was a 6-foot teenager. And the chest felt nothing like the dummy's plastic chest, but having stood there over a body and doing that, I remember thinking, yes, I've done this before, and it brought the tension down like this much. So I'm just gonna say that as a mention of simulation, and the idea of doing things, practicing them in a risk-free setting is very important. So that's all I'm gonna say.
Are there any more questions that we have or people that want to discuss other points?
Rebecca, I did want to ask a question about the experience that, speaking of lived experience, the experience that your transgender patients, role players, had as being part of the simulation. Did they give you any feedback about what that was like and how that worked for them?
Yes, thank you for the question. So we had hired 2 transgender men. One played the role of the patient in the virtual reality unfolding case study, and then the other played the role of the patient in the face-to-face simulations. And the Lee, the one who played the role in the face-to-face simulations, is a very close friend of mine now. We've gotten to know each other really well. And he was able to join in on debriefing with students. And honestly, this was just kind of amazing to me, but he and Colby, the other participant or the other standardized patient actor, had said this was one of the first times that they had ever talked to a majority of cisgender individuals, but especially in the healthcare setting, about their experiences. And it was, they got as much out of it, it sounded like, as students did from being able to participate. So both of them continued in year 2. And then actually this past spring, they came and spoke as part of the panelist group. So it sounded to me like, although, you know, there's always that concern of individuals who are already part of a vulnerable population then being, you know, put on a stage or center of attention and reliving and talking through these things. There's always that concern there, but it sounds to me like the feedback we got was that it was a good experience knowing that they're going to help improve the lives of other people.
Dr. Jalad has her hand up.
I want to discuss about your questions related to simulation. Simulation have different type. Now, when you told about compression, CPR compression, you are right because this mannequin, not as the human. But simulation, we had high fidelity simulation and low fidelity. When we talk for high fidelity, is very important because high fidelity really or mimic real person. And students, before going to hospitals, they have to practice in the lab or in the traditional lab or in the simulation center to prevent any anxiety or stress or to develop their communication with patient, with real patient. This is the problem with our students, how they can break this fear or anxiety with people. Simulation make this opportunity to students, especially for first year students or second year students. Now, simulation scenario is different related to the level of students. When we talk for students first level is different for students fourth year level. And scenario is different between medical surgical course and psychiatric course and leadership course. For example, in psychiatric course, we didn't use mannequin, we didn't use high fidelity, we used standardized patient as actor person, and all of the psychiatry or mental health scenario, this actor make as reality, and the students play as team to know what are the real scenario related to these disorders or this mental or psychiatric disease. Simulation is a good way or good teaching strategy to make role play and improve communication between them. Yes.
Thanks.
This is yes, this is my discussion for this part.
That's a really important distinction to make. It sounded like the simulation that Rebecca and her colleagues did was focused on communication. Is that an accurate description? Did communication in the different ways that it happens?
That was definitely a big aspect, was communicating.
I'd also just like to contribute in regards to our study as a speech language pathologist. One of the things that I like to help my students with to actually help hinder their imposter syndrome is to help them feel more familiar with the setting that's involved. And so one of the big aspects of our study was the inclusion of virtual reality and being able to have the students be in that setting before they actually are there in real life really helped them feel more comfortable, even though they didn't have hands-on patient experiences. They were able to feel like they were in that real life environment using that technology, and that definitely helped boost their confidence and feel like they knew what the expectations were, so that when they went through simulations or real life hands-on patient experiences, they knew what the expectations were, and it helped them feel more comfortable when they came to those scenarios.
I actually, about a year ago, was working with Elsevier on some simulations that they were developing for novice nurses that could be subscribed to by, like hospitals who are bringing on new nurses, and some for undergraduate nursing students. And it was very interesting. I was working with, they were all IT, and I was the nurse who was helping them to get this right. And they were amazing. I'm from Marty's time, sort of, where we didn't have a lot of simulation. We went out there and we just had to go out there and do it. But these were so realistic that we worked on to help, novice students and young nurses learn how to be comfortable in this environment, and how to communicate was a huge part of all this.
Does anyone have any additional questions or clarifications, points that you'd like to make? Well, I know that we are nearing our end, and seeing that we don't have any additional questions, I would again like to thank all our people from Appalachia State and all the presenters for making time at very hard times of the day to join us, and also for your work that you're doing in healthcare and nursing, and improving mental health for people. So thank you from one of the guest editors, and from, as Marty said, I'm one of the board members. So thank you for everything that you do for creative nursing.
Thank you, everyone. Stay well, stay safe and well. Love you
Bye,
all.
everyone. Thank you.
Bye, everybody.
Thank
Thank you very much.
Thank you.
you, Dr. Marty.